And before we begin, I would like to introduce our new CEO, Ms. Lynn Woolridge. Lynn Woolridge is Bermudian and Canadian and joined Bermuda Cancer and Health Center as Chief Executive Officer in June 2018. Lynn has a 30-year career in the life and health insurance and reinsurance industry in Canada and Bermuda. From 2012 to 2017, she served as a Bermuda government senator and junior minister. Prior to joining the center, she was head of international life at the Argus Group. She holds several insurance industry designations and served on the board of the Insurance Association of the Caribbean, as well as on the Council of the Bermuda Insurance Institute. Please welcome Bermuda Cancer and Health Center's new CEO, Lynn Woolridge.
Good evening, everyone. Good evening. Thank you for coming out and helping me celebrate my 3-month anniversary with the center. You have to celebrate every day. Today is 3 months. So thanks again for coming out. As always, I'm told that we have a very diverse group of persons attending this evening, laypersons, survivors, those who are still facing down the beast, those from the medical profession, and the allied health professionals. So thanks for coming out. Thanks also to Bernews and CITV who are recording this evening's presentations. They will not be recording the Q&A part, but we really appreciate the fact that people who aren't able to be here in person will get to find out what was discussed by our two panelists. I just want to introduce the two panelists right now. One of them flew in particularly for this event, and we're so glad that Hurricane Florence didn't come any closer to us because we would have had to scramble to figure out what else we were going to do this evening. So Dr. Susana Campos, she's the assistant professor of medicine at Harvard Medical School. She serves on committees for the American Society of Clinical Oncology, the Gynecological Oncology Group, and the National Comprehensive Cancer Network. She's board certified in internal medicine, oncology, and hematology, and her specific interests include the adjuvant management of advanced and poor histological types of endometrial cancer and new agents for metastatic endometrial cancers. Our other presenter is Dr. Christopher Price. And with Dr. Price's arrival on island and start at King Edward at the end of June, beginning of July, we now have 3 oncologists on island, and we're very grateful for that. So, as I said, he brings the number of full-time oncologists on staff to 3. We have Dr. Ong, Dr. Christopher Fosker, who's at Bermuda Cancer and Health, and Dr. Price. Dr. Campos is U.S. trained. Dr. Price is UK trained. And he is mostly from the Bristol area, I believe you mentioned, in the UK. And in 2014, he moved to the Worcester Royal Hospital to help develop and run a new oncology department. Prior to this cancer treatment facility opening in the rural county of Worcester in the West Midlands, patients in that 560,000 strong population had to travel outside the county to receive the majority of their cancer treatments. Dr. Price has also served as Director of Research and Development at Worcester Acute Hospitals from 2014 to 2018, and he's a Clinical Service Lead for Oncology from 2017 to 2018. So those are our two presenters for this evening. And before I welcome both to the stage, I want to embarrass one person in the room and acknowledge the presence of my cousin, Kim Hendrickson, who did an excellent article in the Royal Gazette today. And I say embarrass Kim because she does not like to stand out and she doesn't really want to be recognized. And the only reason she did that article for Royal Gazette was to bring awareness to other people. She did not want anyone to know anything about her, but she wants everyone to be aware of the symptoms. So thanks, Kim. And now, Drs. Price and Campos, would you please come and have a seat? Okay.
Oh, there's the thank you something. Well, thank you very much indeed for asking me to speak this evening, and thank you for organising and championing the Ovarian Cancer Awareness Month. I've recently come to the island, so I have no previous experience of this programme of talks and events, but it seems an extremely important and useful, worthy cause, and I'm glad to be part of it this evening. I'm going to give a fairly general talk about ovarian cancer and just particularly bring out some of the issues relating to treatment here in Bermuda. And then I'm very pleased to pass over to Dr. Campos for an update on the more sort of exciting and novel areas of treatment that she's obviously closely involved with developing in Boston. So, ovarian cancer, the scale of the problem. So why are we talking about it? Each woman has a 1 in 56 lifetime risk with an incidence that's increasing. Variously quoted as the 4th or 5th most common cancer death in women. But a disease primarily of older women, 80% occurring in women greater than 50. Like most cancers, it becomes more common as we get older. But unfortunately, it often presents late, and there's no effective screening program. Well, the good news is perhaps that survival rates for those patients who are diagnosed with it are improving. This slide really is just there to show the age distribution. This is UK data, and essentially showing that the majority of diagnoses are made over the age of 60, but that it accounts for a significant number of deaths of women in their middle years, in their 60s and going into their early 70s. This slide demonstrates the variation of incidences across European countries, and the point of showing this is really just to show the variation between about 10 per 100,000, the lower end of the scale, Portugal, France, Spain, and at the upper end of the scale, a sort of double that incidence in countries such as Latvia and Lithuania, but Ireland and the UK are towards the upper end of that spectrum. If we come to look at the data for Bermuda, now I've rapidly looked to see what I can find about that, and there may be people in the audience who know more about the database on which cancer statistics are based in Bermuda. This is from the Government of Bermuda Epidemiology and Surveillance Unit. During the years 2008 to 2015, ovarian cancer made up 3% of the total female cancer diagnoses, and that equates to about 6 to 10 new diagnoses recorded per year. But I suspect there may be an underestimate, because it's clear to me, having practiced here for the last 2 months, that there are some women, and this applies to other cancers too, who receive all of their treatment overseas, and it may be that they're not necessarily being recorded. So I suspect that that is, to some extent, an underestimate. The statistics, the figures suggest that it's responsible for 5% of female cancer deaths during this period. And why is that discrepancy? Well, female cancers are dominated by the much more common breast cancer. Breast cancer has an effective screening program, and many patients who are diagnosed with breast cancer are cured by being treated at an early stage of their disease. So ovarian cancer, which typically presents at a more advanced stage, accounts for a disproportionately higher percentage of deaths. This data was collected between 1997 and 2003 from the Bermuda Cancer Registry and was published in the West Indian Medical Journal in 2009. And it relates to an analysis of cancer rates across all types, comparing Bermuda with the US population. One of the findings of this study was that the Bermuda ovarian cancer incidence of 22 per 100,000, again, which provides an estimate of about 7 to 10 cases a year, was comparatively higher than the US population, with a more predominant excess in the Bermudan black population compared to the US black population, although both black and white populations in Bermuda, ovarian cancer was a more commonly presenting condition. So what are the risk factors behind these statistics? Family history of breast and ovarian cancer, a known familial BRCA1 or BRCA2 gene mutation, previous ovarian cysts and endometriosis. There was some interest in the possibility that talc exposure as an irritant or a carcinogen within the peritoneum was a cause, but if that is the case, that's a very small factor. Certainly there haven't been confirmatory analyses or studies. And an increased incidence with intrauterine contraceptive device usage. Reduction, most importantly, reduction by parity, number of pregnancies, and reduction with oral contraceptive use. There's been a lot of interest in the effect of aspirin in reducing the incidence of cancer. And ovarian cancer does seem to be one where this is a genuine effect. This was one study from Iowa where there was a dose relationship, and women taking aspirin up to 6 times per week was as much as a 39% reduction in risk. Other studies since then have suggested that the effect is smaller, and it's not quite clear that there's this dose-response relationship, but it does seem to be a genuine effect, and there was a overview analysis published earlier this year. This slide just gives a little bit more detail about the effect of parity and the effect of oral contraceptive use. So that compared to a woman who's had 3 or more children, a woman who's had no children is at double the risk of ovarian cancer. And compared to a woman who has never used oral contraceptive or has only briefly used it, a woman who's used it for more than 15 years is at half the risk of ovarian cancer. And the oral contraceptive effect does wears off, but it wears off relatively slowly, so that where there has been a lapse of time between 10 and 20 years since oral contraceptive use, the risk reduction still remains around 20%. If the incidence is increasing, why is that? We're all living longer, so cancers of older age groups become more common. We have smaller families. Women are using more fertility drugs. Obesity is a factor. Hormone replacement therapy has been a factor. There is a relationship between height, and therefore in well-nourished Western populations, this is potentially responsible for some of the increased risk. And it can be estimated that about 20% of cases are linked to lifestyle or environmental factors. But early diagnosis really is the key. For stage 1 disease, curable by surgery, 5-year survival is more than 90%. For stage 3 disease, where the cancer has spread beyond the ovaries and the pelvic organs into the peritoneum, 5-year survival is 40%. So what symptoms do we worry about? And it's really important, particularly in this awareness week, that we sort of stress these and give good publicity to them, because these symptoms are fairly non-specific. Pelvic and lower back pain, increased abdominal size and a feeling of bloating, difficulty in eating and feeling full, losing your appetite, persistent urinary or bowel symptoms. Because these are all very non-specific, it's quite easy for these to go on for quite a long time before it becomes apparent that they're not going away and require investigation. So, again, looking at UK figures, up to 50% of women have followed a fairly convoluted pathway before coming to a diagnosis. And symptoms have been present for a median of 12 months before diagnosis. So it's a common problem that these symptoms are not particularly worried about by the patient and not necessarily picked up by healthcare professionals. Making the diagnosis, pelvic examination, use of the CA125 blood test, which is a tumour marker for ovarian cancer, CT scan to define the extent of disease, and then going on to assessment and treatment at surgery. Unlike most cancers, The diagnosis doesn't have to be confirmed by biopsy before the surgeon takes the woman to theatre. The biopsy would only necessarily be done if there were extensive changes on imaging, so that it was considered that maybe surgery wasn't the best initial treatment. I'll come on to that in a moment. Going on to the treatment, the surgeon is aiming to remove all the cancer as far as he or she is able. So complete removal of disease if feasible. If not, because of this tendency for ovarian cancer to spread within the peritoneal cavity, to try and remove as much as possible, optimal debulking, bringing the residual areas of tumour down to as small a possible size as possible, certainly less than 1 centimetre. Drug treatment, particularly chemotherapy, is used in a number of settings to reduce the risk of recurrence for some patients with early stage disease who've been treated surgically. So the cancer has been removed, but we accept that there is a risk of recurrence because of some of the features of their cancer, and going through a course of chemotherapy can reduce that risk of recurrence. For patients with more advanced disease, chemotherapy can delay the regrowth of the cancer after surgery. If, in the case of advanced disease, surgery is not initially undertaken, it can facilitate subsequent surgery by reducing the burden of disease in the abdominopelvic area. But for extensive disease that can't be treated surgically, or for disease that recurs after surgery, chemotherapy can be used to palliate symptoms and also extend survival, even though it's not eradicating the disease. Now, we've got 2 medical oncologists on the panel, unfortunately no gynecological surgeon, who would perhaps give a better take on this. But I just thought we'd run through what surgery for ovarian cancer means. Surgery for breast cancer seems relatively obvious. There's a lump and you remove it. Surgery for ovarian cancer is perhaps a little bit more difficult to envisage. The central component is total abdominal hysterectomy and bilateral salpingo-oophorectomy, TAH and BSO, as it's always recorded in medical notes. Removal of the uterus, the tubes and ovaries. But the surgeon then wants to try and assess how much further the cancer has spread within the abdominopelvic cavity, the peritoneal cavity. And if there is evidence of disease, to go around systematically trying to remove all the identifiable areas of tumour wherever that's possible. So this is quite specialised stuff, and this requires the input of an experienced gynecological surgeon. And so we'll come back to that, talking about services here in Bermuda. Now, how is a woman with ovarian cancer or any other patient with cancer, how's their treatment planned nowadays? So in Bermuda, as in the UK and the States, we discuss a patient's condition, diagnostic features, x-rays, scans, biopsies, in a multidisciplinary meeting, here called the tumour board. I'm used to calling it a multidisciplinary team meeting. And here at King Edward Memorial Hospital, we have a weekly tumour board, and it's attended by the oncologists, the radiologists, pathologists who've been looking at the biopsies, our palliative care physician, family practitioner who may be involved with the management of that particular patient, surgeons, gynecologists, and our pharmacists and nurses. But because we're a small centre, we are very dependent on our good links with the US, and particularly the Dana-Farber, but other centres in the US as well. And how do we run this virtual tumour board? Well, there's direct communication between specialists. I've been very impressed by how easy it has been to access some of the oncologists and surgeons in the States while I've been here, just by picking up the phone or sending an email and getting a very prompt reply. We have very well worked out and prompt electronic transfer of radiological images. And our pathologists, pathology is getting very specialised these days, and there's a heck of a lot of tests that you can run on a tumour sample, a biopsy. Our pathologists have close links with specialist pathologists at other centres, requesting special investigations, special markers, molecular tests on the specimen, but also obtaining second opinions. As referred to earlier, there's 3 oncologists now in the department. I just love this picture. I was in the paper. That's the only time I've ever in my life been in the paper. As an oncologist in the UK, you've got to have committed some fairly serious misdemeanors to get into the paper. I was just going to say, you've got a wide choice now. As long as you don't want a female oncologist, you've got a wide choice. But obviously, we have a team behind us, nurses, administrative staff, pharmacists, and this is a photograph before I joined the department of a very, I think, cohesive and very cooperative team. How do we know what we're doing? I'm really sorry this hasn't projected very well. The NCCN clinical practice guidelines are very well designed so that you can't copy them and put them on slides. But we use these very well updated guidelines, which are produced from 27 leading US cancer centers of excellence, if you like. They're very widely used. They're very well kept up to date. And this isn't an idiot's guide. I don't feel at all embarrassed if a patient comes in and I'm sort of scouring through the NCCN guidelines, because this is up-to-date stuff, and it's very important that we confirm that the treatments that we're offering are standard of care. So I'm just going to give you an example of a patient where the interaction between ourselves and the Dana-Farber was productive, I think. This was a patient who was quite poorly. You're only looking at a cross-section of her abdomen here. She was quite distended, in a lot of discomfort. There's a lot of fluid there, and the radiologist would tell us that there's quite a lot of thickening of the tissues in the abdomen. And those scans were reviewed overseas, and it was clear that this wasn't going to be a good opportunity for this woman to travel over to undergo surgery. So we were recommended to initiate chemotherapy. And here we are after 3 cycles of chemotherapy. Now, the cancer hasn't disappeared, but the fluid has stopped building up, and the volume of cancer is less. And so we're now reviewing these scans with the team in Boston as to whether this is now a good time for the patient to travel and have her surgery. So, Ovarian Cancer Awareness Month. I think this is a very good opportunity to highlight this illness and publicise the very non-specific warning symptoms. I think it's very useful that people are educated about this and they're highly publicised so that people do really ensure that they get an explanation for some of these symptoms if they're persisting. And I wanted to reassure the Bermudian public that we have good arrangements to be able to provide standard of care treatment locally, but we're very dependent on very good links with the overseas institutions and faculty, and that Bermudian patients will have access to standard of care, but also advances in care, including new drugs, and that's what Dr. Campos is particularly going to talk about.
Well, good afternoon. It is good afternoon. And thank you very much for actually inviting me to Bermuda to actually talk about ovarian cancer. I've already taken some very nice shots of Bermuda and forwarded them back to my staff and as well as to my family to make them ever so jealous of the fact that we are seeing beautiful sun and beautiful ocean. So today we're going to talk a little bit about advances in ovarian cancer, and I decided to actually name this talk Celebrating a Tomorrow. And I will tell you that I truly do believe that we are celebrating a tomorrow with ovarian cancer. And it's always important because nothing is important unless it's actually affiliated with a patient. I want to talk to you about a patient that I had way back in 2000, actually. Her name is Kathleen, and I met her a couple of days before the Christmas holidays. And she presented to our clinic with advanced stage ovarian cancer, stage 3C ovarian cancer. And at that time, we had a protocol. It was a homemade protocol. It used conventional chemotherapies, but we called it the modified triple doublet protocol.
and by today's standards, it would have been considered rather boring, frankly. And she engaged in that particular study. And I remember talking to Kathleen, and she said, I said, Kathleen, do you really want to be treated the day before Christmas? Yes. And so we treated her. And that was in 2000. And as the years have passed by, she has had recurrences, and she's struggled sometimes, and times she has not. And I often, sit with her and talk to her about what is it like to live with ovarian cancer every day, because indeed, what it is a chronic disease. And I often say, aren't you tired of us? And she says, no, I celebrate a Tamara every day. She saw her son Brennan get married, and she saw the birth of Juliet 6 years ago. So we really are actually celebrating a Tamara with ovarian cancer, because what we have today is not what we had yesterday. And over the course of the last 17, 18 years, she's been able to change from one therapy to the next, but absorb the benefits of what we have in 2018. So for Kathleen, celebrating a tomorrow. Now, let's talk about, you had a wonderful lecture as to the standard therapies of ovarian cancer. The standard of therapy in 2018 is what it was almost 15 years ago. It celebrates actually the use of two drugs, both carboplatin and Taxol. How we give these two drugs has changed over the last several years. We thought by giving it every 3 weeks, it was the best. Then we changed to giving it every week. And then we also thought that by using intraperitoneal chemotherapy, we could improve the survival of women with ovarian cancer. And all that was true. But in many ways, we've come back to using this compound every 3 weeks. Carboplatin and Taxol is the backbone of ovarian cancer and remains that. But over the years, we've asked ourselves the question, how do we, understanding what the standard of care is, because it's proven its time over the last 15 years, but how do we improve on the standard of care? And so what I'm going to propose to you is novel approaches, okay? And this is applicable to some, and some it is not, based on their disease, where the disease plays itself out, and the potential toxicity. But the novel approaches in 2018 really reflect non-cytotoxic chemotherapies. None of these are chemotherapies. What they do is they augment the benefit of chemotherapy. We're going to talk a little bit about the role of Bevacizumab, also known as Avastin. We're going to talk about the role of the PARP inhibitors, which are these oral drugs that really have changed the face of ovarian cancer in the last 2 years, actually. And we're going to talk about immunotherapy. Immunotherapy, we hear about that a lot every single day. Tremendous applicability in lung cancer, melanoma, renal cell carcinoma, bladder cancer. Is there a role for immunotherapy at the present point in time in ovarian cancer? And what are the studies that are leading to the future? So let's start at the beginning. So, the role of bevacizumab. Bevacizumab, also known as Avastin, okay, basically is an antibody, okay? It is not a chemotherapy. It's a monoclonal antibody that binds to this substance called vascular endothelial growth factor. But it is this substance, vascular endothelial growth factor, that sprouts new blood vessels. And new blood vessels makes cancers grow. And so if you could block that, okay, you could block the ovarian cancer. And what's known is the fact that ovarian cancer is actually rather rich in this vascular endothelial growth factor. Dr. Price showed you a very nice slide, unfortunate slide, of a woman prior to chemotherapy with a lot of fluid in her abdomen. That fluid, okay, is coming from her cancer, and I'd be willing to guess that there's a high VEGF level. Bevacizumab almost absorbs that fluid and takes that fluid down. It blocks a particular substance called vascular endothelial growth factor. What are the studies of this particular drug, and how does it pertain to us in 2018? So this lovely little cartoon, okay, shows you new blood vessels being sprouted. There are 2 publications that really have changed the way we treat patients with ovarian cancer at time 0. And granted, it's not applicable to everyone given the way the disease plays itself out, but in some cases it is. One study was called GOG 218, and another study was called ICON 7. ICON 7 was done mainly in the European communities. Both of these studies showed that if you added chemotherapy plus bevacizumab, okay, that you could actually improve progression-free survival. Now, in ICON 7, which is the European study, if you had a very high-risk ovarian cancer, you then also could improve survival. We did not see an overall survival benefit in 218. But Avastin now, bevacizumab, based on these 2 clinical trials that basically took chemotherapy and added to chemotherapy by the use of bevacizumab, are approved for the upfront management of patients with advanced ovarian cancer. And that is different. The FDA in the United States just recently approved bevacizumab within the last 12 months. So we have that to offer to our patients that come to us, that walk through the door, with high-risk ovarian cancer. If Kathleen had walked through the office today, she would have seen carboplatin, Taxol, and Avastin. So one advance. Now, the elephant in the room is recurrent disease, okay? We do a very good job of putting people into remission with ovarian cancer. But despite carboplatin and despite Taxol and despite bevacizumab, the unfortunate note is that the fact that people do indeed relapse. The question is, when do they relapse? They either are platinum sensitive if their disease comes back 6 months after the completion of chemotherapy, or they're platinum resistant if the disease comes back less than 6 months. So greater than 6 months or less than 6 months has been in the literature where the line in the sand draws. There are a lot of gray zones in between this. I'm going to stick to platinum sensitive disease because that's where actually most of the advances have been made, but I'm happy to answer any questions in platinum resistant disease. Now, over the years, what we have learned, okay, is that DNA replicates on, and DNA makes mistakes when you replicate your DNA. And many times during the course of this replication of your DNA, okay, mistakes are made. But that there are enzymes called PARPs that correct those mistakes. They correct what we call single-stranded DNA breaks. If, in essence, you block the PARP inhibitor by a drug, okay, then what happens? Well, interestingly, if, in essence, you block by giving the individual a PARP inhibitor, if they have a normal way of replicating their cells, the cell survives. But in essence, a very neat little trick, okay? If in essence the individual has a mutation, for example, a BRCA1 and a BRCA2 mutation, and they cannot repair their DNA, if you take those type of situations and add a PARP inhibitor to it, the cancer cells die. It's a very nifty little way of killing a cancer cell in BRCA1 and in BRCA2 mutation carriers. Basically, it's PARP inhibition. Now, in the United States, there are 3 PARP inhibitors that are approved for the management of patients with ovarian cancer. Specifically, olaparib is a PARP inhibitor that is approved if, in essence, you carry a germline mutation. You inherited that gene from your family members, okay? The second PARP inhibitor, which is called rucaparib, is interesting because not only did they know that if you have a BRCA mutation that you inherited from your family, okay, you could respond to these type of drugs. But what if your tumor in and of itself created that same mutation? You didn't inherit it and you can't pass it on, but the tumor in itself created it. You would have a somatic mutation. And it was clear that the PARP inhibitors also had activity both in a germline as well as in a somatic mutation. And rucaparib got approval about 1.5 years ago for patients that had a germline mutation as well as somatic mutation. And this was important. Why? Because PARP inhibitors were only able to be given to patients that had a germline mutation until rucaparib became approved. And as such, okay, we now expanded the use of these drugs to more than just germline mutation carriers. Now, niraparib is also approved. We'll talk a little bit about that in maintenance therapy, and so is olaparib, and so is rucaparib. But at the present point in time, olaparib and rucaparib as single agents for the treatment of ovarian cancer with germline or somatic mutations. Now, over the years, I've been talking to you about BRCA mutations, whether you would inherit it from your family, whether or not the tumor in itself makes that mutation. Interestingly, we used to think only of yes or no, but over the last several years, we've realized that it's not only BRCA1 or BRCA2 that actually have a deficiency in repairing their DNA. So what we've learned, and you think about the red portion of it, that there are a group of individuals that despite the fact they are not BRCA1 or BRCA2 germline, okay, they have genes or proteins that are missing that are important in the repair of the DNA. And can those individuals also respond to these PARP inhibitors? And the answer is yes. And this came to fruition by looking at this in certain maintenance therapies. Now, I'm going to present to you some data that sometimes is a little complicated, but it's really not, okay? And there are 4 trials that I think are incredibly important and really have changed the way that we treat platinum recurrent sensitive ovarian cancer. These are maintenance therapies. I mentioned to you that we do a very good job of putting people into remission the first time, but the disease comes back. And the question is, how do you keep this disease away? You do so in the presence of maintenance therapy. And for years, we looked for maintenance therapies, and we found nothing that came to fruition until the PARP inhibitors. So we have the NOVA trial that looks at one particular PARP inhibitor called niraparib. The SOLO2 trial was done specifically only as it was designed in what we call germline mutation carriers that used a drug called olaparib. Some of our colleagues abroad, study 19, looked at olaparib as maintenance therapy in all comers, and then just recently approved by the FDA in the Aerial 3 data was the use of rucaparib also as maintenance studies. But take a look at some of the caveats of this particular trial. So I'm going to walk you through some of these. The very first trial that I wanted to talk to you about, I think is one of the trials that was so exquisitely designed. They asked the question, if you give individuals a PARP inhibitor after the completion of chemotherapy, assuming they respond to chemotherapy, will you let them live longer without disease? Is there an improvement in progression-free survival? Is there an improvement in overall survival? And they looked at this very strategically. They said basically, we'll divide the group of individuals into those that we know have a genetic mutation, a germline mutation. So it's those that had a mutation versus those that did not. And within each of these 2 categories, they said, we'll give the drug to half the people and half the people will not. So they studied the people with the mutation and they studied the people without the mutation. And very interestingly, what you see is the fact not only did this drug improve progression-free survival in patients that were BRCA mutation carriers, they improved progression-free survival in all individuals, irregardless if you carried the germline mutation, the somatic mutation, or not. What was key from this particular study was the fact that the magnitude of benefit across these 3 groups was different. The individuals that got the highest benefit, I should say, is the patients that did indeed have the germline mutation. But those that did not still actually got a benefit. This drug is now FDA approved for patients that have recurrent platinum-sensitive ovarian cancer as maintenance therapy. That's one study. Is it the only study that exists? It is not. These studies have been replicated over and over again. This particular study is called the SOLO2 trial. In many ways, it asked exactly the same question, but in this particular study, it was designed differently. They specifically, at time 0, decided to look at patients with germline mutation carriers. And again, they randomized the patient to a PARP inhibitor, in this case, olaparib, versus that of placebo. They asked the exact same question, can you improve progression-free survival? And very similar to the study that I've shown you previously, that in germline mutation carriers in the SOLO2 trial, you improved progression-free survival. You kept the disease away longer, in this case, germline mutation carriers. Not the only study. And you can see the benefit. The next study was the study 19 study. So in many ways, we ask ourselves the question, well, should we restrict it only to germline mutation? This study did not. But this study also replicated in many ways the niraparib, the NOVA study, because in this particular study, they took all comers. And this particular study, they again showed that regardless of whether you carried the BRCA mutation or not, you actually had an improvement in progression-free survival. The very last study, okay, is called the Aerial 3 study. And this just simply used a different PARP inhibitor, in this case, rucaparib. Same story, okay? They asked the question whether or not you improved progression-free survival in the germline or somatic carriers. And at the end of the day, this particular PARP inhibitor improved progression-free survival in all comers. So regardless if you are a BRCA mutation carrier, whether you're germline, somatic, or not, there's an improvement in progression-free survival with the use of the PARP inhibitors, which are oral drugs in platinum-sensitive ovarian cancer. This changed the way we did things in ovarian cancer in the last 2 years. My patient, Kathleen, was found to have a BRCA1 mutation status and actually was able to undergo certain clinical trials with the use of a combination of olaparib plus a different drug. Now, everything sounds grand, okay, when you hear about the data, but you also have to balance that with the potential side effect profile. So although these agents are tremendously efficacious, they do have side effects. They have both GI side effects, they have hematological side effects, and in extremely rare cases, it can cause leukemia. So when we use these drugs, as glorious as they are, we must be mindful of the fact that what are the side effects and how does one circumvent it. But clearly, a huge advantage to the patient population with ovarian cancer, the PARP inhibitors. Now, a story is not a story until you actually see results, okay? So this is a patient that at baseline, okay, had about a 5.3 centimeter mass in the anterior abdomen in red. After 4 months of being on the olaparib PARP, if you can see it, it now measures approximately 18 millimeters. So clearly these drugs have activity. In a similar light, there's a patient at baseline who had a mass in the left upper quadrant measuring approximately 23 millimeters, and after 4 months of therapy, you can barely see that there's anything there. So when they work brilliantly. And this is a patient, at this point in time, these were germline carriers, so it's important to make note of that. So clearly efficacious. Now, where do we go in the future? If these drugs work when a disease comes back, the most logical answer is, do they work up front so that we can prevent a recurrence? And that data is actually still pending. In about a month at ESMO, the European Society of Clinical Oncology, Medical Oncology, there'll be a presentation of the first trial, the SOLO-1 trial. The SOLO-1 trial asked a very simple question. In patients that have a germline mutation, a BRCA1, BRCA2, if you gave them a PARP inhibitor after they finished their chemotherapy, right from the beginning, could you improve progression-free survival? No one has seen this data, okay, but it will be presented at ESMO, and we know the preliminary results is that the study was positive. How positive, we don't know. We'll know in about a month. The next series of studies actually just do some very interesting combinations. I spoke to you about Bevacizumab, Avastin, in management of ovarian cancer. The Paola study will combine not only the Avastin, but will combine olaparib, the PARP inhibitor, in hopes of improving progression-free survival. So what we learned from patients that have relapsed are now being taken to the upfront setting with ovarian cancer and really trying to change the course of women with ovarian cancer. So these studies, we'll know what SOLO-1 said in a couple of weeks, and we wait for the maturation of those other studies. Now, a lot of hype about immunotherapy. Immunotherapy is extremely interesting. It has tremendous efficacy in patients with melanoma, renal cell carcinoma, lung cancer. You all know, you've seen all the commercials on television, okay? The question really is, okay, does immunotherapy have a role in ovarian cancer? And how does immunotherapy work? So this is a very basic cartoon, because this is all I can draw, okay? But when you think about it, okay, one often asks the question, I have an immune system. Why doesn't the immune system just fight off the cancer? They can't fight off the cancer because the cancer has a mask, okay? But if I had a drug that simply took that mask off the cancer, a monoclonal antibody, okay, the immune system then would have the opportunity to actually see and recognize the cancer and do what the immune system has always supposed to be doing, and that is killing off the cancer cell. It's a very simplistic way of looking at it, granted, I know, but in essence, that's basically what it boils down to. Unmasking the cancer cell so that the immune system can actually visualize it and do their job. The question of whether or not immunotherapy has a role in ovarian cancer is still unknown. If you actually look at some of the clinical trials that have emerged and have been presented at some of these major meetings, the response rates are marginal at best, okay? Approximately somewhere between 8 and 12%. But the duration of responses are longer. So the question really is, as single agents, do they have activity? Well, maybe yes, maybe no, but maybe in combination, they're much more resourceful. I kind of want to share with you a clinical trial that we did at the Dana-Farber Cancer Institute, and it was done all over the world for that matter, and it's recently closed. And so we don't know the results yet, but I just want you to be aware of this, and hopefully in the next year and a half, we'll have some preliminary results. It's called the Javelin 100 study. And basically, we took the backbone of chemotherapy, carboplatin and Taxol, and what we added was a monoclonal antibody that is what we call a checkpoint inhibitor. Targets the immune system. And this is kind of a simple design of what we did, what was done in the study, I should say. We did not write it, we participated in it. basically patients either got chemotherapy alone or they basically got chemotherapy plus the Avelumab, which is the monoclonal antibody that basically unleashes the immune system. We don't have results. This study has closed. It's been done all over the world, and hopefully I would hope that we have some preliminary results in the next year, but it will be some time before we ask the question, if we give a monoclonal antibody that targets the immune system up front with ovarian cancer, do we improve progression-free survival, and do we improve overall survival? The question is still unknown at this time. Now, this is a picture of immunotherapy in ovarian cancer. So when it works, it really works, okay? This is a patient that had ovarian cancer, but metastatic, a particular type of ovarian cancer called clear cell histology, which is oftentimes very, very resistant to chemotherapy. And as you can see, the lung mass in this panel, it was about 6.9 centimeters in the right lower lobe. And after week 25, that had shrunk to 4.1, not with chemotherapy, but with a biological therapeutic, in this case, an agent that targets the immune system. You hope that that can come to fruition for everyone, but this is an example of when it works, it actually works. Not only do we have these drugs, but when we combine immunotherapy with, for example, other drugs like Avastin or Bevacizumab, the hope is that, in essence, we might get more activity in patients with ovarian cancer. So there are many combinations that are actually starting to come to fruition. So where are we actually in 2018? Basically, there is a very bright future for patients with ovarian cancer. In 2000, when I met Kathleen, we had chemotherapy and chemotherapy only. Over the course of the last 18 years, we've introduced hormonal manipulation, drugs that block the vascular endothelial growth factor, the PARP inhibitors, and immunotherapy is still a question, but something that we're studying. The PARP inhibitors are probably the most exciting class of drugs in the treatment of patients, all patients with ovarian cancer. And immunotherapy, that is actually being investigated. One particular trial was the Javelin 100. There are numerous trials that are starting to come out. There's a study that will open shortly worldwide called the Tesaro trial, the first trial, that looks at not only immunotherapy but PARP inhibitors as upfront management of patients with ovarian cancer in combination with standard chemotherapy. And I think the answer may be not only in one drug. It always takes a village, okay? And the truth be told is the answer may not lie in one drug, but maybe how drugs actually interact. So I'm actually incredibly excited. I'm holding out in terms of the role for combination therapy. Actually, I think that in essence may indeed what we've been waiting for such a long time. So we are indeed celebrating tomorrow with ovarian cancer. So thank you very much for your attention.
Thank you, Dr. Campos and Dr. Price. At this time, we'd like to say thank you to News and CITV for being here and recording. And at this time, they will be turning off the cameras, and we will be opening the floor up for question and answers.